Well, first, I guess I want to thank everybody and welcome you here to this little event. Our goal has been to assemble a couple of different healthcare owners and to explore a little bit about the emerging science around what I guess I would frame as aerosol transmission of infectious disease. Certainly this particular one and the implications for what we do in the future. And in many ways, the COVID virus has been a catalyst for learning and thinking in ways that we haven't really had access to in some ways. The National Academy of Medicine last week had a 2-day seminar on the science around aerosol transmission, and in particular around the COVID virus, but around aerosol transmission in general. It was absolutely fascinating, and clearly this is an area of intense and emerging interest. Jim is going to do a little bit to summarize some of what we know at this point and how that's evolving. And you know, many of you I know on this call have been involved with ASHRAE and other organizations who are doing amazing work in this field. ASHRAE, I was fortunate enough to be part of a group that put together something ASHRAE called a position document on infectious aerosols, which really tried to bring a strength of recommendation taxonomy to thinking about the ways we use different strategies in design of systems and ventilation systems as mitigation strategies around the risk of transmission from infectious aerosols. And I think that's a really interesting paradigm for how we move forward into a world of new and different and emerging threats. I do think in many ways it signals opportunities for the regulatory community because we are having access increasingly to data and information that we didn't have before in terms of how things work. And that creates, I think, tremendous opportunities for us. Obviously, the technology is evolving. Some of the work that Kaiser is doing around looking at measuring what really happens and what really goes on in spaces, I think provides interesting opportunities for continued exploration and continued improvement about how we think about how we can do better. So at any rate, I want to shut up in many ways and get on with the science and the collection of facility people we have who are going to tell us about how their learning has evolved over time. With that, I want to introduce Mr. Jim Crabb. Jim is a mechanical engineer who has been doing a lot of work for us in assembling the science around these issues.
Good afternoon. So we want to talk today about infectious disease transmission and some of the science around that, and which is sort of evolving right now. We know that infectious diseases are transmitted through droplets, surface contamination, and aerosols. And the thinking around the contributions between those three modes of transmission has been changing somewhat in the last, well, very much in the last 5 months. But that is really bringing to light some changes that have happened over the last 5 or 10 years, maybe more than that, of research. We know that outbreaks of infectious diseases occur most commonly indoors, and the current thinking is that aerosol transmission really dominates the airborne respiratory viruses, at least. So what does it take to actually infect another person? Obviously a susceptible host and exposure, but exposure is really a probability. There's the probability of being infected increases. There's very little absolute, but it increases with concentration of the virus in the air and the time of exposure, which has to do with how much of it you breathe in while in the presence of that concentration. So the debate really has been a lot around what is the infectious dose that it really requires for this particular virus. And that isn't really settled yet, and it probably never will be. But what we do know about aerosol transmission is there are really three zones that we should concern ourselves with in the context of a healthcare setting, at least.
Hey, Jim, I'm
Yes.
sorry to interrupt you, but it's hard to hear you. So can you try to speak up just a little bit?
Okay, is that better?
Yes, much.
Okay,
Thank you.
sorry for that. The three zones that we need to think about are the plume, the room, and the system. And I won't take credit for using that terminology. That came out of the NAM conference last week. In the plume, we're talking about directly in the plume of the infected person. So the droplets are coming out, and some of them are very small, some of them are larger, and a person in the zone of that plume is going to have both potentially receiving direct droplets and also a fairly high concentration of the aerosol. And the aerosol is just the very fine particles that are coming out, but also some of those larger droplets are going to evaporate over time, over a very short time, and become aerosolized themselves. So we really need to start thinking also about the room. And in the room, you're not exposed directly so much to that plume, except maybe in the case of a sneeze, but you are exposed to the overall concentration that starts to develop in the room. And that's influenced, of course, by the ventilation in the room. And the concentration changes pretty dramatically compared to being in the plume. You may achieve a dilution factor of 300 to 1 in a typical patient room. But that still isn't really safe for the kind of infectious diseases we're talking about, COVID in particular, not without PPE. And even with PPE, the time really should be fairly limited in that room. So that's all been pretty well settled. I think we've all kind of understood that around COVID. But the question has been, is there any effect at the system or building level? And really at the building level, you can achieve a very high dilution ratio, 10,000 or more, plus the effects of deposition of those viral particles, decay as the virus becomes inactivated, and then of course filtration at the air handling unit can make a huge difference as well. Even the MERV-14 filters that we typically use are pretty effective. So what we really want to talk about is not so much of those modes of transmission, but what are the tools that we need to be using. And I'm thinking particularly of ventilation engineers and how we approach ventilation in hospitals. The old tools that we have used were air change rates. We said that according to the CDC guidelines published back in the early days of the TB crisis in the 90s, we need to do 12 air changes per hour in an airborne infectious isolation room. Unless it's existing construction, then we can do 6 air changes per hour. We need to keep it at negative pressure. That's been defined as 0.01 inch negative. All the air needs to be exhausted. Unless that isn't practical, again, thinking of existing spaces, then we need to HEPA filter it and it can be recirculated. Typically, we're designing for constant volume airflow. So these are the tools we've used, and we've said basically if you have 12 air changes and you meet these criteria, you have a safe room. But of course, most hospitals don't have enough AII rooms to handle the number of patients that have been coming in. So what we really need are some new tools. And a lot of those tools are being developed right now. We can actually measure viral copies in patient rooms. And there have been some of those measurements that have come out in the last 6 months. They don't all agree, so it's not entirely determined yet. We have a lot of different models, mathematical models for infection risk, rather than just a black or white, 0 or 1. There's a risk associated with different concentrations and different situations. We actually have studies now that have documented the amount of air that transfers through a door as the door to an isolation room, for example, opens and closes, even as a person walks in each direction through the door, and how much air escapes. So if we know the concentration in the room, we have a sense of the number of viral particles that might make it out into the corridor. We've got lots of measurements of hospital indoor air quality. We're going to talk a little more about that. A lot of CFD modeling is being done now, and just a real abundance of research from around the world. One of the new tools we have is the ability to measure indoor air contaminants, and this is a sensor that we used for some research we did, sponsored by the California Energy Commission in cooperation with Kaiser Health, and actually did some measurements. And one of the interesting things we found, I won't go into a lot of detail about this one, but we expect there to be a relationship between ventilation rate and the contaminants in a room. That's kind of why we do ventilation. But our measurements over the course of several months have shown very little relationship between the air change rate and the particulate level and other pollutants, but we're talking about particulate level here. Very little relationship between those two things, which is surprising. And we're still trying to figure out what all that means. There's been a ton of research. This is just the folder I have with the research papers that I've been looking at to varying degrees. And this is a snapshot of the research that's out there. One of the things that CFD has taught us is that airflow path really matters. There have been a number of studies on this, including one done by Mazzetti that was published in 2011. And what this is really showing you is that the placement of the air distribution devices in a room can make a big difference. The one on the left is sort of classic mixing ventilation, where we just count on mixing everything up in the room and then it gets exhausted. The one on the right here has actually changed the location of the return over here, and the supply is right next to it but blowing out this way. And this red here is the path of particles going straight back to the return or exhaust. That's an idealized situation, as most CFD models are, but it does suggest that there might be a better way. The Mazzetti paper actually demonstrated that in a room with 4 air changes with proper ventilation design, you can actually be more protective of a healthcare worker than a room with 12 air changes with more standard design. Poor design is what they called it. We also know that HEPA filtration is very effective. This is a topic I just keep harping on because we've seen a lot of people in the last 6 months who use these portable HEPA filter units, and they just use them to blow out to the outdoors. And you're taking air that is very, very clean and discharging it. What we know is that HEPA filters are essentially absolute filters, 99.7, 3 logs reduction. There's another study that actually looked at the emission rates. This is actually a mathematical model, not measurements. Emission rates of a person who is speaking and a person who is coughing, the distribution of the particle sizes, and then looked at what the concentrations in a room might be. And this is a graph from that same study. And they were looking at it from the start of time. And so you see these big differences over time as with different air change rates. But the interesting thing here is that really in a healthcare setting, in a patient room, you're not dealing with an event, you're dealing with a continuous emission. And that's what I've sort of highlighted here in this box, is that there's really a steady state concentration in the room that is really related to the ventilation rate, not the room volume. Over here, the room volume is controlling to some degree, but once you achieve a steady state, air change rates aren't the issue, it's just straight up ventilation rate. So what we are suggesting is that there needs to be a different way of thinking about hospital ventilation. And the codes are going to need to change to reflect this, in my opinion. But what I think we need to do is come up with a consensus model. There are a lot of scientific papers out there right now that are modeling the probability of infection under different circumstances, and there are variations in those models, but they're just math, and they're things that we can understand. So as engineers, we could be using a model to look at what the ventilation rate really needs to be, and then adapt that to a specific organism. It might be that at the start of an epidemic, we don't know as much, but what we've seen with COVID-19 is the amount of research has fed us a great deal of information in a very short time. And if our ventilation models were built to use that information, then we could be doing things more rationally rather than just 12 air changes, negative pressure. I think we need to be using CFD modeling to design our healthcare spaces. The cost of doing so has come way down. It's not free, but it has come way down, and that it's a very effective tool. But just generally speaking, I think we need to use math, physics, biology. We need to use science to determine what our ventilation requirements are. Right now, we're using outdoor air as though it is the clean standard. Outdoor air is most effective for gas phase contaminants. One of the things we discovered in the study we did in cooperation with Kaiser was that the inside air in a hospital is way cleaner than the outdoor air. And that was just with MERV 14 filters. So outdoor air isn't necessarily clean. It has to be filtered in a hospital in order to be clean. So let's think about the outdoor air as a way to reduce the concentration of gas phase contaminants, CO2 and other volatile compounds. Let's use clean air, whether that's outdoor air that's been filtered or recirculated air that's been filtered, and think about that as our ventilation for particulates. But most significantly, I think we need to be focusing on a ventilation rate. Maybe that's a CFM per person or per square foot and per person, just like we do in ASHRAE 62, rather than basing our ventilation on the volume of a room, because the volume of the room is really not what governs. And I'll stop there and pass this on to our master moderator for today, Donna Deckard. Donna has been serving the healthcare industry for over 40 years, including 30 or more years with Kaiser. She led the implementation and optimization of KP Health Connect, in addition to consulting roles focused on driving evidence-based design in healthcare. Donna is currently the Director of Strategic Projects for the Center for Health Design, a founder of the Built Environment Network, and serves as the chairman of Mazzetti's Board of Directors. Donna?
Well, thank you, Jim. And thank you, first of all, so much for providing some information about the science and how the COVID-19 virus is transmitted, and some of the recommendations for potentially managing ventilation systems. And Walt, you talked about how organizations such as ASHRAE wanted to be responsive and provide guidance to addressing the operation and maintenance of ventilation and air conditioning systems. However, I think there is and still remains some confusion about what should be done. And there's still lots of new information coming out, as you just demonstrated today, Jim. So health systems across the United States and internationally had to make decisions to respond to COVID. And there really wasn't a single answer that would work for all of them, as each one had different types of facilities and were in different areas of the country. And so today, what we wanted to do was hear from 3 health systems, not only what they did, but also why they made the decisions that they did. And I think what you're going to hear is not only lessons learned, but they're going to talk about what they're doing now and what their plans are for the future. So let me introduce our panelists. Each of them has a very unique and different story. And as they tell their stories, please feel free to type any questions that you might have in the chat box, and we'll try to address as many of them as time allows. So let me begin, and gentlemen, you could turn on your cameras. Clayton Mitchell serves as the Senior Vice President for Real Estate and Facilities for Thomas Jefferson University and Jefferson Health, which is based in Philadelphia, Pennsylvania. And Mitch joins Jefferson coming from Kaiser, where he served in various capacities for the past 8 years in national facilities, both in Colorado and the Mid-Atlantic regions. Jefferson Health, through 5 mergers and acquisitions, has grown from 3 hospitals in 2014 to now 14 hospitals and a university. Mitch's role there involves development of a corporate real estate master plan, infrastructure upgrades, and facilities acquisitions and consolidations for the enterprise. And he draws upon not only his experiences gained from Kaiser, but a 25-year career in the Navy. Mitch has a degree in industrial engineering and a master's in civil engineering with a concentration in construction management. So Mitch, I still don't see your face on the screen. Mike Wood. Mike Wood is a healthcare design and construction management executive that specializes in very complex programs, systems, multiple project types, and team collaboration, and has led national and international organizations, programs, and project delivery teams, and large-scale capital programs for over 35 years in both Europe and North and South America. Mike is currently the VP for Planning, Design, and Construction and Energy for Medxcel. And Medxcel manages the facilities for Ascension, the largest nonprofit healthcare system in the world, with over 168 hospital campuses in 29 states. Mike holds degrees in organizational development, business management, physics, and is also a physician and a radiologist and a cardiologist by background. Mike is a past regional vice president of IFMA and was recently named a faculty fellow of the Center for Health Systems and Design in the College of Architecture at Texas A&M. So did George join us yet? Doesn't look like it.
George he was pulled into a bit of an emergency, but he will join in 2 minutes.
Okay.
He will be with us.
Okay, well, great. Well, let me introduce him then, and when he joins us, you'll know who he is. So Dr. George Tingwald is a director of medical planning for Stanford Health Care, which is located in Northern California. And with an unusual combination of skills and expertise, George applies his qualifications as an architect and doctor of medicine to create practical and efficient designs for healthcare facilities. George has, at Stanford, he has fostered the planning and design of over $4 billion worth of construction over a 10-year period. So let's go ahead and get started with the panel. And Mitch, I want to start with you. I'm hoping that you can get your camera to work. Let's have you talk about what you did, why you did what you did at Jefferson Health to prepare for the pandemic, and why you made the decisions that you did. Mitch, can you hear me?
He's muted.
He's muted.
Hey, Donna, can you hear me?
I can.
Okay, sorry about that. I think we're having some significant internet issues here at my complex, so my apologies. But really, for Jefferson, can you hear me now?
Yeah, we can hear you. Can you turn on your camera, or will that take down your?
Well, my internet's actually down. It's trying to come back up right
okay.
now.
All right.
But just to leverage off some of the background, just when we talk about the why of Jefferson with the pandemic, I think it kind of starts with some of my past experiences, both within the Navy, dealing with a lot of contingencies, disasters, hurricanes. We were first responders to Hurricane Katrina. You know, we're responders to tsunami issues in the Pacific and a lot of other areas. The challenge is always, you know, can you have the capacity that you need ahead of the emergency that you're meeting? And so as we were looking at Jefferson in the early stages of COVID, you know, we had questions about capacity. Did we have bed capacity to address all the need for our patients in the greater Philadelphia community? Or our building system capacity adequate to meet the need? You know, we had a conversation, we have some links with Europe, and we had a conversation with a health system in Italy. And we saw where more capacity became a crucial issue for a lot of systems, both in Europe and in Asia. And then there's this issue of systems modifications. And could we make systems modifications to increase negative air pressure and other, you know, sort of opportunities to mitigate what we thought were the risk of COVID-19. And then, of course, there were command and control issues. And so all of those became really key sort of the determinants in terms of what we would do early on to head off COVID-19. One of the things I will say, and I'll start off with, is, you know, I got some results back from our Senior VP of Quality today, and the infection rate of our patients and staff inside the hospital we're right around 1%, which was about a third of comparable health systems in the Northeast market. So we were doing pretty good in terms of protecting people, and we've done pretty good in terms of keeping people safe, particularly during the height of the surge. So the question is capacity. How much capacity should we plan to provide? And from a real estate and facilities perspective, what we determined is, you know, we've got to set some constraints, and you know, in our system, we think that we are about 1 million square feet more than we actually need. And so what we convinced our leadership was it was prudent just to plan to use our 15 million square feet of capacity within Jefferson and no more. No modular capacity, no contingency capacity, just optimize the existing capacity of our buildings in terms of space. When we solved that question or put that constraint in place, it made it really easy for us to start to plan in terms of ventilator capacity and other building systems capacities that we needed. And we had to do a lot of early sort of analysis to ensure that we had adequate oxygen capacity and all of those different systems requirements in order to meet an emergent need. We did make the decision early on that we have 61 spaces from a morgue capacity standpoint. And so from our discussions with our counterparts in Europe, we determined that we did need to bring that capacity to play. We did that through refrigerated sea containers that we outfitted as portable morgues. But in terms of systems modifications, which were really driven, the desire for those was driven by a lot of our medical support staff. Our VP for quality and infection control partnered with real estate and facilities to say, you know, we can really do more by changing people's behaviors, making sure that they had PPE, and that was a better value proposition for mitigating outbreak spreads inside of our hospitals than attempting to try to modify, particularly in the heat of the outbreak, when you know, building permits and entitlement and all those types of things that we would need from the city would have been challenged. And so, you know, with the key health stakeholders of quality and infection control, helping to drive that decision or drive a lot of those decisions with our executive leadership. We had a lot of support from our board of directors to the CEO, to the C-suite, even down to the staff, to really assume that our facilities were built for infection control, particularly the hospitals, use that as our baseline premise, avoid potential unintended consequences of trying to modify systems on the fly, stay with the proven empirical technology and basis of design for existing facilities, and then subsequently, we're not only able to bring safe facilities, safe environments for our staff and our patients, but we are also able to avoid a lot of extraordinary or excessive costs. Just to close it out, we think that by taking that perspective, we not only kept our patients safe, we avoided probably anywhere around $50 million worth of modifications that would have been necessary to create the amount of negative pressure rooms that our folks were asking for. And we also avoided mission impacts of trying to do construction and other invasive work in our hospitals at a point in time when they were under a critical surge with COVID-related patients. So I'll close right there.
Okay, thank you, Mitch. I'm going to move on to Mike Wood. Mike, you had probably a different answer, given the number of facilities and the multiple states that you had to make decisions about. So can you tell us what you did? How did you decide what to do, and how did you get agreement on the path forward?
Sure, be happy to do that. Thanks, Donna. And thanks, Mitch. You set it up really well. I'll just make it really short. Ditto, and then we can close. Well, let me add a little bit of color to that. Mitch, really set it up really well in terms of lots of us as healthcare systems as we compared notes, and we did. A lot of healthcare systems got on the phone with each other and started to connect very rapidly, regardless of the business cards. And I think all of us had the same mission in mind, quite frankly. Number one is protect our patients. Secondly was, for us at least, was protect our providers, all the way from a housekeeper all the way up to a surgeon, the entire spectrum, in our case, including landscapers who are working outside the building, and everyone in between. And really third in that chain, if you will, and this isn't in any sequence, is protect all the caregiving associates, and then our families that wanted to access, their loved ones inside the environment, whether they were symptomatic, asymptomatic, or had nothing to do with the COVID surge. So that was number one. Really kind of a combined mission: protect our population and our communities. Like Mitch outlined, we responded very quickly. I got called out of a meeting on a Tuesday afternoon. By Tuesday evening, situation had changed. By Wednesday morning, we were asked to stand up a national command center. By Thursday morning, it was a series of command centers. And on Saturday morning, our command center was up. Fairly rapid deployment, if you will. And we used, like Mitch referred to, we used our disaster-based command center structure. So we already had in essence, a skeleton already built for natural disasters in our portfolio, literally from Texas over to Florida and then up the East Coast and primarily Midwest. Tornadoes, hurricanes, et cetera, are a fairly common occurrence, and we're pretty good as a system at that kind of deployment. What made it a little bit more interesting, as our COO will attest to, is we had to add in people into this structure that normally were really not involved in those kind of conversations. So we went deeper in the clinical operational staff, not just the chief operating officers, the chief nursing officers, et cetera. And we actually brought in infection preventionists across the system as members of the conversation and decision-making organization. So kind of backtrack just a shade, our first initial response was establish a strategy. Jim, you alluded to this in your remarks. Even if you're talking about, HVAC systems and controls, it really is get your strategy right first. So we had a lot of noise, if you will, in the system that says, go to deployment, go to deployment. And thank goodness our leadership said, no, we're going to stop, even if it's a 2-hour pause, and we're going to go to strategy first. And our CEO, the CEO of Ascension, who is our major client and service organization, Joe Impichike, took a stand, stayed on his, if you will, his stand, and has been a great leader throughout this entire event of these are the things we're going to do and these are the things we are not going to do. And thank goodness for Joe and his number 2 guy, Craig Cordola. The second thing we did was immediately form collaborative teams, very cross-functional, all the way from supply chain, finance, operations, all the way down to engineers in the boiler room, HVAC mechanics, building automation control people, vendors, supply partners outside of our system, and internal. And a number of people probably on this call, and a number of you actually in the speaker version here, Jim included, have been on a number of our collaborative teams and watched us go through decision struggles and, if you will, make a decision and retract, get more data, get more research, make another, strategic move. Like Mitch, one point I would agree with, we elected very early on to stay the course, do our research, use the empirical evidence, stay with evidence-based design, and as much as we possibly could across the entire system, stay the course. Don't overreact to something that we don't know. We don't know how much harm we could do by altering the environment. At that point, we don't know how much good we can do. So we had to use the research we had at hand to stay the course as much as we possibly could. What our teams came to at the strategy level, I think, were the 2 primary words, if you will, that really became the mantra. We provided guidance and governance across the system. And we did that with a team of subject matter experts that were led really by, I'll call it a project management expert, that became what we've called the acronym FAST, FAST. They named themselves, by the way. Some of the acronyms I can't even repeat on this call. One of them, the one I can repeat, one of them came up with is the Avengers. And almost on day 2 of that team, they were wearing capes, even though they weren't evident. So the Avengers kind of fit, but they came up with the acronym FAST, F-A-S-T, Facility Assessment and Support Team. But an incredible group of people, started with about 12. Right now, it has now become a permanent standing committee, not only related to COVID, but other events. And that team is numbers roughly 25. And it continues to get deeper in subject matter expertise and experience about what to do to the built environment. Some things that we struggled with, like everybody, I think, you have to struggle with the age-old thing in healthcare. It's business versus mission, or mission versus business, right? So how do you maintain the mission of healthcare when you have to support it financially? And so that was a part of the equation, quite frankly. We had to figure out how to keep our patient population and our community safe, but we also had to figure out how to continue do business continuance. As Mitch alluded to, if you run a calculator at all and you've had first level 101 accounting, it doesn't take you long to get to 40 or $50 million by the time you can ratchet through these conversions of rooms and the costs and the time implications, displacement of, call it a normal patient population for an infected patient population. We did the same thing. And we said we can't afford, if you will, the ripple effect. So give you some data points. We converted right now, we track these very carefully. We've converted roughly 200 spaces, and they range literally from a patient room or an OR and an ante-room environment all the way to entire wards. And really, with a lot of work by creative people, our cost across our system is roughly $2 million. That's not our reconversion cost, but that's our initial first cost. And we're very, very conservative about what we do, how much space we do, all those other parameters that come into play. There are two, I'll call it, engineering principles that are behind this, and this really aligns with what Jim alluded to. One is we wanted to treat in place as much as we possibly could. So if we had a symptomatic COVID patient, we wanted to keep that patient, in essence, treated in place so that we weren't moving that patient throughout the environment and we weren't exposing, intentionally or otherwise, someone else to that infectious disease or infectious process. The other thing we wanted to do was, and this becomes where the debate goes on, right? And it alludes to the research that Jim actually put up earlier. We really wanted to filter at the source. So like Jim alluded to, we installed systems, even on a temporary basis, even temporary fans, if you will, HEPA filtration, MERV 14 or better filtration. We did 100% exhaust solutions. That's really kind of our magic sauce, if we had any, is to do 100% exhaust solutions. In some cases we couldn't, and we had to reroute, not do drastic changes to the primary HVAC systems. We do a whole lot of that with this FAST team, if you will, and then they reach out into the rest of the, if you will, the healthcare community, HVAC, ASHRAE, ASHE, FGI, et cetera, to continue to get guidance. And I will, I'll pretty much close at that, Donna. As you know, with the system, the size of system we have, and Mitch alluded to this, even with the Jefferson system, the moment you move the rudder, a half a degree, the front of the ship, the front of the boat is going to go 15 to 20 degrees off. So we've been very, very, very careful about providing guidance that's on target, that is isolated, but that adheres to really design guidelines, known principles, not trying to reinvent a wheel and not trying to create a wheel that is brand new and has unintended consequences. What we'll do going forward is very intentional. We're now part of the ECC group from the Facility Guidelines Institute. We're participating with Texas A&M and other research. As a system, Ascension is participating in a number of, I'll call it epidemiological and biological studies related to COVID and other infectious disease. And we are then revisiting, as Jim alluded to, and Walt, in your opening remarks, what does the built environment in healthcare really look like? And what have we done to ourselves that we're going to have to do very differently in the future? And I think there's a lot of room for us to explore those opportunities. And we as a system are on those first steps of that stairway. So. And Mitch, thanks for tipping it up so well. Ditto, dude. Appreciate it. Thanks, Donna.
Sure. Thank you, Mike. Well, while we're waiting for George, I think both of you took very different approaches. And as we said, when you first started, there wasn't a lot of information out there. So how did you manage the questions and about ventilation with your leadership, with the clinicians and the staff and risk managers? I mean, were you both able to convince them? You both took different paths, but what did you do and why, how did you convince them that what you wanted to do was the right path forward?
I think, can you hear me?
Yeah.
Yeah. So, when I came to Jefferson about a year and a half ago, and, we were already in sort of what I would call a turnaround transformation mode for real estate and corporate facilities. So we laid out this vision, and the vision really aligned to a lot of the things that we're having to do through COVID and post-COVID. Real estate rationalization and realignment. So optimizing utilization of our real estate, reducing waiting room spaces and things of that sort, making those spaces more efficient, and then really trying to sort of extract greater value from an operations standpoint and a real estate standpoint. Leadership, our board of directors, our CEO, they had bought off on that strategy, and they were very convinced that that was a strategy that we needed altogether. And so when COVID hit, I think we had a reservoir of credibility to have hard conversations with them to really constrain the problem. Because one of the biggest issues is, like, how much capacity do we really need? And I think we were able to help them, you know, sort of put an operational constraint around what they needed to do from an operational standpoint based on the real estate. That's where real estate, we didn't want to be, you know, the tail wagging the dog, but I think we helped them constrain the issue. We built that credibility up front. So when we started talking about these issues that Mike and Jim and Walt were talking about in terms of the modifications to facilities, and Mike's exactly right. He's got 100 and some odd plus, right? I only have 14. But if I do a $3 million modification to one hospital, I literally have to do that across the system. That's $50 million. And if I do it in one, and I can't guarantee that I get the resources to do the others, there's an issue of parity. So it's less about, is this the cost thing, but is it the right value to get the amount of safety that's actually needed? And is that going to be credible safety? Can you document that things are actually safe? I think the other part of it is we couldn't document that what we did wouldn't cause a second and third order effect that would have caused other problems like Legionnaires, cross-contamination, all of those things. And oh, by the way, our Department of Health said you can convert those facilities under this waiver, but once COVID's gone, you need to convert it back. So now it's not 50 million, it's 100 million to get it back to its default state. And so I think our infection control leader and our VP for quality totally understood our perspectives on that. And really what we came to a conclusion is personal behavior was really the most value added investment in there. So if we could use PPE versus modifying systems, you know, for a lot of money and not a credible bang for the buck or evidence-based bang for the buck, we would be. And they bought off on that. And I think our credibility as real estate facilities rides really high with Jefferson right now, the equal business partner, because we help them make some key and hard decisions through this event.
Okay. Mike, any response?
I would echo most of that, actually, a great deal of it. And we were really blessed. Literally 6 months prior to this, we had a major change in leadership. Call it from an old style leadership to a very new style leadership. So two gentlemen, Joe and Peach K and Craig Cordola, came aboard as CEO and COO. And they were both past operators. And so, you know, frankly, we were really blessed that when we had those conversations, as Mitch alludes to, with folks who had been in an operations leadership role before, they understood it almost inherently. And we did have some interesting spirited dialogue around, you know, timing and cost and unintended consequence. And quite frankly, that dialogue led to a lot of the solutions that we put in place in terms of, are you nuts? There's no way we're going to do that. And sometimes it was the leadership doing that, and sometimes it was us as saying, no, we can't take a whole wing of a whole brand new hospital and just flip the switch on the wall and go from positive to negative or completely revise an environment. And that actually spirited dialogue led to really creative solutions, which kept our costs down. And to Mitch's point, what we found out is signage and enforcing the PPE, enforcing the distancing, working with things like, you know, entry doors, going to our elevators and saying you'll have no more than 4 people on an elevator at a time other than a patient transport. I mean, some of the behavioral changes, which were needed anyway, frankly, have really led to long-term reductions in, you know, symptomatic patients, ICU cases. I mean, we are, as a system, we're down below our influenza level right now with the COVID patient population, which is amazing, given what we know in the general population. So, again, I can't overemphasize, take your strategy first, you know, don't fire, aim, and figure it out.
Jim, I want to ask you a question, and then Walt, I think I'll probably have you talk about what happened at Stanford, since I'm not sure if George is going to join. But Jim, one of the questions that came in is, when you were talking about the science, somebody wanted to know what's considered a safe air exchange rate, and then because we are talking some about ventilation, and then I think what we want to do is transition to, what do you guys want to thinking about now that you have some information, now that you have some data? What do you plan to do going forward? You did some things in the midst of Corona, but now what do you want to do going forward? And then, also talk about, future facilities and what the design is. And Walt, that's where I want to have you talk a little bit about what happened at Stanford, because it's a very different kind of facility than, what we've got here. So, but Jim, can you just answer sort of from a science perspective, what do we, the information and data that keeps coming out, what's considered safe, what should people be thinking about in terms of ventilation going
So
forward?
I will answer that question, but first, since I now have the microphone, I want to echo something Mike Wood just said.
Okay.
My boys did Boy Scouting and they did wilderness first aid, and first aid in the wilderness is really critical, right? Because you can't call for an ambulance. And one of the first tenets is don't just do something, stand there. Flipping the normal statement on its head. Stop, pause for a moment. Nothing is so urgent that you can't take a few seconds to figure out what you really need to do. And particularly with teenage boys, that's good advice. But anyway, to the air change issues. So think again about those three zones we talked about. In the plume, ventilation's irrelevant, air change rate's irrelevant, size of the room is irrelevant. If you're in the plume, you're in the plume, and you better have good PPE. Otherwise, that's the only thing that's going to protect you. Now, there are ways that we can improve the capture of the aerosols that are being generated and reduce the concentration in the room. But for a healthcare provider right there with an infectious patient, or for a subway rider right there next to an infectious person, PPE is the only thing you've got, or don't be there. In the room area, so that's where we normally think about air change rates, of course. And in a room, even 12 air changes is not necessarily protective. Inside a patient room with a known infected person, you should have PPE to protect you. 6 feet doesn't matter, because typically in a room, you achieve a concentration level in the space, and unless that concentration is really, really low, there's a risk. There's a high risk. Even at a low level, there's a risk. And so, again, it depends on how long you're exposed. Typical healthcare worker, though, going in and out of patient rooms, the PPE, the respirator is really the primary protection. And at that point, if I was a healthcare worker, I would want an N95 or better. When you get to the whole building, the whole system, that's when dilution really starts to work in your favor. And then you can count on a little more decay in the virus. One study has shown that the half-life of the virus in the air is about 70, 75 minutes. So that is working in your favor on the large scale. Filtration, if you put HEPA filters in the air unit, you've cut down the concentration to such a great degree that there's really nothing to be concerned about at that point. But I would not count on ventilation in any patient room, no matter the rate, to be safe. And safe meaning I didn't need to have PPE.
Thanks. So, Walt, the Stanford hospital just opened in November of 2019, and I know Mazzetti did a lot of work on developing the engineering for that. But so they took a pretty different tack than what Mitch and Mike did. You want to just talk a bit about what was built into that hospital, and then that hopefully helps us segue into thinking about what's for the future. we've got to get through COVID, but there's going to be other viruses, other infections. So how do we really plan and design for the future as well?
Right. Clayton, I think you need to mute, maybe. I'm hearing a lot of background noise. So I'll do my best to channel George Tingwald, which is an impossible dream. But I'll just talk a little bit about that particular new building. I mean, George was lucky in that he had a brand new building. And in many ways, in the course of designing that project, Stanford tends to treat the sickest of the sick, and they wanted to spare no efforts in some ways in looking at and investing in systems that would really help in a range of circumstances. And so just a couple of things that are built into the ventilation systems there. First off, they used displacement ventilation, which many people have heard us talk about in the past, I'm sure. But it's really interesting to me to think about. I mean, one of the advantages of displacement ventilation is that it removes particles from the breathing zone more quickly than other ventilation systems. Now, I don't know that it matters. And so one of the interesting things that we're talking about is, Jim mentioned earlier the research that was done with the California Energy Commission and with Kaiser Permanente, looking at ventilation. I'll use the word effectiveness in quotes, sort of real world ventilation effectiveness, I guess I would say. And one of the things we're looking at doing is taking the same setups that we use there and installing them in the Stanford facility to understand, actually, did it make any difference? Does the displacement provide a benefit of any significance? And so that'll be very interesting. And we're going to do that as part of another California Energy Commission grant. So this will all be publicly available information. So that's, I guess, the first thing that, they didn't have to do anything about it. They also had in place a system that allowed them to isolate any individual patient room and to make it negative if they needed to, or to take a wing and make it negative if they needed to. And so with literally the flip of a switch, and I think they were on the phone with, our people to enable them to do that. And it was, in the early days of the pandemic, we didn't know if negative pressure was going to matter, if that was important, but they had the ability to do it. And so they were able to do it more easily because they had that starting out. The other thing is they were using both HEPA filters and PICO filters. And if anybody wants to know what a PICO filter is, they have to ask Jim Crabb, because he's been answering my questions in the background. But those are the things that were built into the design. And I think that really gets to this question about, all right, what is everybody going to do? Somebody asked in the Q&A, okay, fine, what are you going to do going forward, right? What does all this mean for going forward? And I will say this about the Stanford projects. I talked about the fact, or maybe I didn't talk about this. Sorry, one more thing I want to say is there's an additional provision built into their system that allows them to be on 100% outside air and completely exhaust the rooms, or to be 100% recirculated. Because in California, of course, right now, I could show you the air quality outside my room, and it's pretty bad because of the record-breaking wildfires that are all around us. And so we've got to protect ourselves against outside air, and we got to protect ourselves against inside air in some ways, right? And so Stanford has the ability to go back and forth. Well, all of this stuff did not come at no cost. And I can't tell you exactly what the cost premium was, but what's, I think, an important consideration is that, each of these things, we were talking to Don Orndorff of Kaiser a couple of weeks ago about some of these things. And Don, said, listen, every one of these investments is like an insurance policy. We can pay the money and we can have that capacity sitting there to save us if that bad thing comes. But how much insurance can we really afford and stay solvent? And I think those are really critical questions for healthcare facilities today. And I think with not clear answers, frankly. And you know, I think it is really seriously a question of risk management and how can we best quantify the risks that are likely to come at us, and how do we both prepare and then react, because those are two different kinds of situations.
Yeah. Yeah.
So anyway, I hope that answers your question.
Yeah, I think so. And, you know, I've got a fairly detailed question here, and then I really do want to transition to, you know, what you were just talking about, Walt, and some of the questions coming in from the audience about, you know, what do we do for the future? But there's a very specific question here about, instead of HEPA filters, can you use electronic air cleaners or a combination in the air handlers? This person was a air handler designer and wants to know how to design or advise clients on the future of air handling. Yeah, so I don't know who wants to take that, but if you want to address that specifically, and then let's talk about, you know, what are you going to do now for COVID, and what are you thinking about, you know, moving forward into the future? So Jim, do you want to take that, or Mike? I saw you.
I'm sitting here waiting to speak. You bet. So
Jim.
there,
I mean, Jim. Oh, Jim, I meant. Sorry. Yeah.
There are a lot of technologies out there that are being suggested primarily by their manufacturers as solutions for COVID and every other virus and bacteria out there. And if I sound a little dismissive, that's probably because I am, because none of these technologies have gone through the kind of testing that would allow me to say to a client of mine, put this in and you'll be protected. Walt referenced PCO, photocatalytic oxidation, and I know he knows what that's what it meant. He just didn't want to show off. But photocatalytic oxidation, there is bipolar ionization. The traditional electronic air cleaner is really an electrostatic. It charges the particles and then collects them on plates, which is, those things are all have some effectiveness. Are they effective enough to hang your hat on them? Are they effective enough to send somebody into a facility that's depending on those and feel like that person is protected? My answer is no. I hope that there will be more study done on all of those to show whether they're effective or not, because it would really be great if we could just put a little system, you know, a little electronic thing in an air handling unit and poof, make everything go away. I don't think that's impossible. I just don't think it's been demonstrated yet. Some of these technologies have been around long enough that the science could have been done by now, and it hasn't been.
Yeah.
One exception, I will say, is ultraviolet. We do know that ultraviolet is effective, and we have a pretty good idea what it takes, but it's relatively expensive to do in an air handling scale. It can be done, but it's relatively expensive, and by the time you do that, you might be better off just putting in HEPA filters. I'll stop.
Rich, did you guys go down any of those?
Yeah. Well, I was going to just echo Jim's previous sort of monologue when he talked about the plume, right? Nothing he talked about is going to keep, it's going to protect people who are within that plume. And that's usually the person-to-person contact between the infected and the non-infected. And so I think we have to also avoid this placebo effect of saying we put all this technology into the buildings and people let their guard down, right? They don't use PPE because they think that the building's protecting them. And I think that's one of the reasons, Jefferson, as an early adopter of PPE, mandatory across the board, was able to keep our infection rates of our staff down.
So we had, just to add another similar voice, almost day one, we put a database together called Alternative Solutions Database, and had another leader actually managing that database. We ran down, I call them bunny trails, but we ran down over 200 bunny trails lots of them related to this particular topic, and none of them that we could find hard research that would, and Jim, I would agree with you, that would allow me to put my personal medical license and other licenses at risk and say, this is the one, or this is the two or the three. The science just isn't there. There's intuitive science in some cases, and there's intuitive silliness in some cases. We had one in particular who wants to put wristbands on people. I mean, looks like the old tennis bracelets, right? And say that's going to be a COVID, you know, an anti-COVID device. That's where the Avengers came into play. But there is hard science, as Jim alluded to, in the UV range of solution. But boy, the expense of it versus the benefit, you know, what's the utilization? Is it on all the time? Is it off? You know, half the time it goes on and on, the iterations of that. When do you reach the silly stage, right? What are we going to do in the future? And we'll talk about that a little bit more. But bottom line is we all have to go back and really study truly HVAC systems related to this particular, call it family of infectious disease, whether it's COVID or other Ebola, it doesn't matter, and really start to do the research. What we are doing is really teasing apart our current planning and design standards and saying, okay, are those applicable? You know, do they make sense in a new environment? And we will go back and change those. It's obvious that they don't. So.
And well, Mike, why don't you tell us what you're planning to do, what you're doing now, what you're planning to do for the future. I know you mentioned earlier the fact that you're sitting on the FGI group that's looking at, you know, updating some of the standards and guidelines. But you know, what do you think people should do? You know, we've got all different types of health systems in your system and Mitch's system, and then people on the call, and, you know, a lot of safety net hospitals, you know, that don't have the dollars to be able to make some of these changes. So what are your thoughts and recommendations about what you're doing and what people should be doing for the future?
Let me start with the simple stuff, you know, and really truly simple stuff. Get in the conversation. Really truly join in the conversation. Don't be shy of it. Don't wait. Don't sit on the sidelines. Get in, understand, you know, what we're all dealing with, and find the group that can resonate with you, for you, and speak for you or advocate for you, but get in the conversation. That's probably number one. Number two is follow the research. Really, truly follow the research. The research will lead you to a pretty science-based, evidence-based solutions. Pay attention to what FGI is doing. Pay attention to what ASHRAE in particular is doing. Get involved in those conversations, that knowledge base, that knowledge share, the webinars, read the articles, etc. Be able to separate the chaos and the noise from the true research. We will be, as a healthcare system, particularly here in the US, and as Walt alluded to, worldwide, we will be looking at our HVAC system standards and have we over-designed, over-isolated, at what cost? What can we do in I'll call it original build to really protect ourselves or anticipate these situations? We can't flip over every hospital bed into a, you know, private room and 100% exhaust it. That will, for lots of different layers, economically, patient treatment, et cetera, it will drive everybody out of the business or nuts. And we don't want to do that. But for my money, get into conversation, be a part of the solution. And quite frankly, begin the process of understanding what this is about. This isn't about COVID. This is about really understanding the environment that we've now created. And we now have to figure out, how do we take this, I would call it in some cases a very overprotective environment, and begin to really address it.
Real quickly, there's a question that said said that you looked at a list of a lot of alternative technologies and whether or not, I don't know if you have that list consolidated enough that we could send it out to people, or was it just too many things to really look at?
Let me talk to my leader and figure out what she's got together.
Okay, great. Mitch?
It was pretty much first time, into the log and away we go. It's an Excel database, so we can separate it.
Okay,
Be happy to share it back with you, Donna, and then you guys can distribute it.
okay, great. Mitch, you're saying that we can't hear you, or?
Oh no, I was going to say I was just on mute, so I don't know where that noise is coming from.
Yeah.
But where we're headed. First off, I gotta do a hat tip to my operations and maintenance staff. Ed Sampe, Bart Miller, Jeff Schmidt, all these guys that we had on the front lines making our systems going. And our systems are pretty old, but they're fairly well maintained. One of the risks that we have going forward is, we have a huge deferred maintenance backlog across the industry. And so we have to be very, very prudent about adding anything in terms of capital requirements that goes on top of that while we're in this work as an industry to get back to black. So I think we have to be very prudent and understanding what are the passive things that we can do. In my mind, that's PPE, that's people's behaviors and things of that sort. And then what are the things that we have to do, just what I'll call just basic blocking and tackling to sustain our facilities through this year with these huge backlogs of deferred maintenance that we've accumulated. And so I think, you have to look at health systems as an ecosystem. And the things that I'm thinking about aren't even technical at all. It's how do we make that ecosystem more robust? The early warning system, which is CDC, which is the federal government, and that part of the ecosystem. Now we know that the health is a vital part of that ecosystem. And now we know that another pandemic, our economies can't even afford to go through that. And I look at a pandemic, we talk about, these things happen every 100 years. There's a lot of different things that could have been pandemics, if we had not been able to address them. And so now I think we know, it's back to that saying, a good decision today beats a better decision tomorrow. I think our decision to split our shifts with our maintenance workers, we took all of our maintenance workers and distributed them across 3 shifts. And we did that to create separation amongst them, but actually it was 4 shifts because we took another shift and put it on reserve. Because we had no idea if we were going to get workers that get infected, we'd have people on the bench that were ready to just kind of go in. We made that decision almost day 1, day 2. The PPE, all those things that we did early up front. I think we had 1 maintenance worker get infected, and our public safety staff I think we had about 8 or 9, and we lost a person. And then across the entire system, I think we lost 2 or 3 people. So we you don't want to lose anybody, but relatively, that behavior change over the technical change trumps. It's that whole culture trumps strategy. And then I would say when we go forward, we want to be leading edge, not bleeding edge. So we get hit, like, Jim talked about all these, great ideas coming in terms of how to solve the problem. But again, it has to be a holistic solution. And we can't forget that even though we put these technologies in place, there's a requirement on people to, exhibit proper behavior to get us through those. And so I think, some of the things that we are going to probably double down on from our standpoint is digital transformation, our ability to remotely operate our HVAC systems and a lot of our building systems. It continues to evolve, but we see opportunities to evolve that even more so that we don't need human intervention in a lot of places, that we can begin to build in some of those capabilities that George talked about with Stanford. And we can begin to use sensor technologies. I remember going through Hewlett-Packard labs, and they had a sensor the size of a quarter that could measure 14 to 15 different attributes. And so when those sensors begin to help us understand airflow, lighting, all of those static type things, But if they start to get into the biological things, biology, mold, and things of that sort, we can better understand how whatever infection or outbreak that hits our facility is propagating itself through our facility and address it where it is. Because I think where we're headed is reliability-centered maintenance. And that's where do I have to put my OpEx investments in the best place to mitigate risk, right? And so the peanut butter spread of just, you know, coming in and saying, hey, I think I'm gonna get a higher level of safety by just ramping up everything, and instead of 12 air changes, it's 24. There's got to be evidence around there because there's energy impacts of there, there's other operational impacts of it, and oh, by the way, there could be a safety implication. So I think from a Jefferson standpoint, we just want to see the evidence behind any code changes or design changes that might be brought forward, and we really need to see what is different about any particular outbreak that makes us have to put special mitigations in place beyond the infection control requirements that were originally designed into our buildings, and that are really based on years and years of empirical evidence. So I don't normally throw the baby out with the water and say what we've been doing is wrong. I think we just need to understand this particular pandemic. Are there particular impacts that we really need to change the design going forward? If not, I think we stay the course and we work on the maintenance and operations side, and we work on people's behaviors.
Okay. You know, there's a lot of background noise, and I don't, if I could ask all the participants to put their, hit the mute button. I think I can't change that for everybody, but if people could do that, that would be really helpful. I know, you know, I think we'll finish up with kind of what Mitch was saying and what Mike was saying, and then Walt, I'm going to turn it back to you. We've got a couple more. Jim, there's one more specific question about whether or not, in looking at the science, if humidity has come into consideration. Could you address that? And then I think in general, there's a lot, you know, we know more now. We have more information, we have more data. You know, FGI, I think, is doing some work. Maybe Mike, you can talk about that and what they're trying to do, you know, helping people think about going forward. And then Walt, also, I'll let you finish with talking about kind of where ASHRAE is going as well. So, but Jim, do you want to address the question about humidity?
Briefly, yes. There have been a number of studies about relative humidity and different viruses and bacterial infections. I don't think we have any specifics on COVID that are definitive. The problem with much of the humidity analysis that's been done is some of them say, well, if humidity is above 80%, that reduces the lifespan of the virus out in the wild. Well, that's almost an irrelevant point because we're not going to run our buildings at 80%. We'll have mold growing everywhere, and that'll be its own problem. But there are some that say 40 to 60% might be helpful. And what I've seen in some of that literature is between 40 and 60% reduces the viability of some things and increases the viability of some other things. And I don't take this as dismissing that information or that idea, because I think it is important. If raising relative humidity in hospitals to 40% instead of 20 or 30% made any significant difference, I think that was something we would certainly want to consider. But I would also point out that very, very commonly in our buildings in North America during the summer months, and where I'm in Atlanta, summer starts at approximately March. Relative humidity in our buildings is already pretty high. It's 50% generally, maybe between 50 and 60. So if there's a protective effect, we should be seeing some of that already. And then in the winter, it would get worse.
Okay. All right. Mike, I'd like to have you talk about some of the work that the FGI is doing and how you guys are using and planning to use that and how that's going to get distributed to the community at large.
Sure. Just real quick, and I'm not speaking for Doug Erickson and his organization, but Doug and the organization put together a new committee as a result of this, plus other, if you will, events like this, called the Emergency Conditions Committee. And from that body of work, there's 140 some odd people, all the way from committee leaders to contributors, editors, et cetera, and researchers. And what we are doing now is, I think at the moment, it's going to be called a supplement to the FGI. And that supplement will be published roughly about 12 months from now. It's going into public review as a white paper, which is a collection of research and writings on this topic. We are, the ECC has a September 15th self-imposed deadline. There'll be some editing and it will become a white paper, if you will, mid to late fall, and then go out for public review and public comment, and then come back for really technical editing, and then a body of work to run it by other AHJs across the US healthcare system, whether it's ACA, OSHPD, states, local authorities, et cetera. And then it would become a published supplement to the FGI documents. And it is a combination of how to prepare for events like this, how to be prepared, and then what an appropriate response may look like. And it really is a guidelines document. A number of people on this call probably may even be on those subcommittees. An immense amount of work by a large body of people with vast years of experience, whether it's a natural disaster or one such as this. Really, truly an impressive body of work done very, very rapidly. So that is moving. Many, many, many authorities having jurisdiction are on in those conversations. Most of us as major healthcare systems are in those conversations. Definitely engineering and evidence-based issues that we debate seemingly, it seems like hours per week. But so that is going on in the background to give all of us as a healthcare system another set of tools and guidelines to use. Again, guidance and governance, right? We're trying to stay out of a governance, if you will, situation and stay much more into a guidance situation. So
Great.
Thanks for letting me talk about that. So
Thank you. Walt, I'm going to turn it back over to you to wrap up and make any final observations and comments.
All right. Thank you, Donna. I will say, just 1 second, I want to reflect on one other question that was asked, because I have an extra minute, and that was the issue of, somebody asked about climate change, which I think is an interesting question in this context. And I will say, on a completely separate track, we've been working with the National Academy of Medicine on a paper looking at the intersection of climate change and health. And one of the things the National Academy is looking at is in making decisions around risk mitigation strategies. How do we start to take climate change into effect, into consideration as we're thinking? In particular, thinking about a mask that has to be made and transported and maybe thrown away against a ventilation system. They're complicated questions. And I don't think there's a clear answer, probably less clear answer than there is to the question of which ventilation system is right. And you had asked me earlier to reflect a little bit on what ASHRAE is doing, and I certainly, like Mike, I don't want to speak for the organization of ASHRAE, but I will say a number of organizations are really trying to think deeply about this question and about what needs to be done. ASHRAE is certainly one of them. ASHRAE is working on an update of the infectious aerosols position document, which will attempt to try to relearn and study and express and think through the implications of the really quickly advancing science. And so that'll be really important. The World Health Organization, you know, they took a lot of heat, of course, for their reluctance to say that the evidence proves that this is an airborne disease. And so they've got a group of people, Jim and I are involved in that group, that are working on this issue from an international perspective. So between FGI, WHO, the National Academy of Medicine, ASHRAE, there's a lot of people who are really working hard to try to figure out and give better guidance on the, based on the science, right, of these questions. And so I second everything that Mike and others said. And I'll just maybe close with one thought. I was on the phone earlier this morning with somebody from the IHI, the Institute for Healthcare Improvement. And we were talking about a number of these kinds of issues, actually. And, you know, IHI was in some ways born out of the 100,000 Lives campaign, really thinking about how do we create systemic change to improve the health and safety of the patients, the occupants, the caregivers, you know, all the stakeholders. And this person leads the innovation group within IHI. And one of the things this person said was, you know, regulations do tend to become fossilized and sometimes prevent innovation. And that is one thing that I think we need to figure out how to do better in the regulatory world, is find ways to be nimble as we can, but also to find ways to allow innovation to occur. And one of the things that she left me with, she said, you know, in IHI, they have, and I'm not an IHI person, but this, I'm sort of now inspired to become one. But she talked about in IHI, we have a philosophy of all teach, all learn. That really, at the end of the day, each one of us can be and should be a student, and each one of us can be and should be a teacher of others. And Mitch said earlier that he wants to be on the leading edge, but not the bleeding edge. But in some ways, I think I want to be the scalpel, right? I want to be the one who is trying to make the new knowledge happen. And I think to some degree, that's where we all need to be. And then find effective ways, whether it's FGI or ASHRAE or WHO or whomever, Built Environment Network, the Center for Health Design, right? There's a lot of avenues where we can come together and share the things that we learn as rapidly as possible. We're lucky to have the technology evolved to learn faster and to communicate faster and more effectively. And I think we have a duty to each other to do that. And so let's all be part of that process. And with that, am I the last word?
Yes.
All right. Then I guess I want to thank you all. I think somebody said we are going to send out all the slides. If we didn't get your questions answered, we'll try to find a way to do that. And I really, this was a little bit of an experiment itself to see, you know, how effective. And I'm sorry that George couldn't be here. And so I just want to thank all the panelists. I want to thank all the people who helped make this happen. I want to thank all the attendees. And please, if you didn't get your question answered, please reach out and we'll make sure that you do. All right. I wish everybody a great day. Wash your hands, wear your mask, stay well.